CHCQM, and FACHE. He served as a corporate medical director, HCA Incorporated, USA, and is also an physician at the Memorial Medical Center, Nebraska. His vast experience bridges both clinical practice and healthcare management. Naganna Cheganna, he is a certified physician executive CPE, certified professional in healthcare quality, and a certified healthcare quality management physician advisor. He worked across healthcare delivery facilities and progressive leadership roles. He started with critical care access facility in rural Missouri to territory referral centers. He has worked for non-profit and for-profit healthcare organizations, including a graduate medical program. He served in a leadership roles at a state and federal government healthcare organization. He served as a medical director for care in the community at Nebraska Western Iowa Healthcare System, Department of Veteran Affairs. He oversees healthcare delivery to veterans across 4 states in the community. He is currently serving as a corporate medical director, denial management at HCA Incorporated. He also keeps his medical care delivery by working as emergency department physician and as consultant at Chennai Healthcare Consultancy Limited. With great honor, I invite Dr. Naganna Chenaviraya to take over the session.
Okay. Good afternoon, everybody. Thank you so much, Dr. Sajita, for a very nice introduction. I hope you can all hear me well.
Yes, sir.
Yes, sir.
Yes,
sir.
sir.
Thank you.
And also, please make a Dr. Naganna as a co-host so that he can share his slides.
Yep. Let me see.
Yeah, you are a co-host. Now you can share.
Yep. Okay. Let's share the.
Please make me also as a co-host, please. So then,
Okay. Can you all see the slides?
yet to come, sir.
No?
Yet to come.
With a few. Okay, let's see. Okay, so notes.
Or Dr. Shine, you can share. Shall we try from this side?
Host tools
Yes,
to
fine.
share. Okay. Yeah, okay. Yeah, I'm probably gonna do that.
Just try it from the bottom, sir. Share
Yeah, so
down.
yeah, so which we did, and let me make
Then
sure.
we put entire screen share.
This
Can you
share.
see my screen now?
Yep.
Here.
Yeah, the AI. Yep. PowerPoint. Yep.
క్లాస్ ఉంది ఆయన 6 days కి పెట్టాడు 20 నుంచి 25 వరకు అది కరెక్ట్ టైమింగ్స్ 1 స్టార్ట్ అయింది
Okay, Prasad. Okay.
Jason, if you have the copy, you can share from that side. I sent you yesterday.
Yep. So yeah, so go ahead and turn it on, and so the host tools share settings,
Hey,
so which I
Ram.
did, but I
అది
can open
వెనకాల
on.
బ్యాక్గ్రౌండ్ ఏం పెట్టుకుని పెట్టుకుని పద్ధతి వినిపిస్తుందా?
Prasad, you want to be co-host? So Prasad, is he from your place, sir? Nagana, sir?
Not from our place.
Okay.
Host tools for share, remove from the toolbar. Okay, so I think I may need to use the AI to help me out here. Okay, let me see. Now the slides that I send it for sharing.
Yes.
Can that pull up?
Yeah, I can pull up.
Yeah.
Can you see now?
Oh, yep, I can see. Let's go to the presentation mode. Okay,
Are you
great.
okay?
Thank you. Thank you all. So we'll start with my prayer to my the teacher, Sri Siddhganga Swamiji. That's where I did my early education. Next slide, please. So, as I mentioned, today's talk is about artificial intelligence in healthcare. Dr. Sujita mentioned about all of my training here. I did do an executive MBA at Washington University, which did help me with some of this leadership role during my working years here in the United States. In the United States for almost 28 years, progressively starting from a small facility all the way across. Next slide, please. Yeah, okay. I started with a very humble beginning in a small rural town in Ramnagara. Now it's a district. And from there, I went to Siddhganga Mutt for my early education. And then I did my MD from Bangalore Medical College. I'd been to several places in the USA, some of the big cities as well as small cities. I worked as a hospital inspector for the Missouri Department of Health, where we used to go and look at the credentials of the hospital, see if they meet certain standards. I also did as a department chairman and program director. I was training the doctors to be a good doctors in the family medicine. I also worked across the 4 states for the Veterans Affairs. I'm currently working as a corporate medical director in the Dynamics Management of Health Corporation of America. They have about 192 hospitals across the US and also one in United Kingdom, where I do more on the revenue cycle to get the money back to the enterprise. Next slide, please. So this is my family, me and my wife and 3 kids, and of course I do have 3 dogs, and they're all having a good time with us. Next slide, please. So let's come to the real topic. Before we start, I would like to thank our organizers, Dr. And Professor Sojan, who reached out to me through a colleague from Siddhganga Institute of Technology. It came as no surprise. He himself, as a devotee of Siddhganga Mutt, we connected very quickly and then went over some of the things that happening in the artificial intelligence. And it's a great honor to be here making this presentation. So what is artificial intelligence? Probably if you Google search or ChatGPT search, you would get this answer very quickly. It's an ability for the computers to imitate cognitive human function. That's very important. What you and me and somebody else is thinking, what will happen if the computer start thinking in the same line? And it is learning and problem solving. So as a physician, you will learn so many things, but you put all those things as a part of the puzzle and then come up with the problem solving. and that using the math and logic to simulate the reasoning that people use the new information and also to make decisions. So pretty much whatever you and me are thinking and trying to do as a provider or as a nurse or a CNA or somebody else. CNA means certified nurse anesthetist, where the computer can think and might be able to do the same thing. So we already probably have done early beginning of this in terms of looking at like say chat GPT, which does this your auto correction of your typing and says give an option, hey, is this what it mean? Do I need to correct it? Or it could be recognizing in a bunch of in a group of people certain people that it is what it is looking for and picking up some of the clues from that. Some of the intelligence community, especially in the defense department, do this one a whole lot. And then we also have this chart boards that can actually recognize the pattern of what we say, what we do, how many times we click. And that's what it means. The computer is recognizing the pattern and then analyzing it and then trying to give an input out of this one. Next slide, please. I do not believe I have that option to, yeah, thank you. So this is basically one of the earliest one. It's called Palm Pilot. If you go back to the development of the artificial intelligence, it was basically to solve the people's problem. One of the biggest people's problem was keeping the stuff handy. Say, for example, here, there are some of the features that says collect all the people's phone numbers. You just put them in together and then it will put them in alphabetical order. It will modify it the way that you are trying to use it. It does not do a whole lot of thinking, but it was a very very basic stuff that will help you to organize and also put them in the order that you wanted to set them up to. Next slide, please. If you go back to the other thing like the Apple iPhone, which is came up very early on in I believe in 2001 or so. It was a clunky one, but it was doing a basic things, basically recognizing the same thing what Palm Pilot was doing. They added more phone that can actually make and does all the functions into it. So these are what I think is the earliest thing that started with the artificial intelligence. Of course, in the defense department, they were doing a lot more that was not public even during those days. Next slide, please. So why all of a sudden this in the artificial intelligence is booming? When we go back to the internet service, so the network connectivity is the one of the biggest one wherein we can connect so fast, so quick. Think about the days that we had to learn everything by book, reading the whole book, going through the book again and again, versus what we do now. Most of the learning is done online as well as through the network connectivity. Big data, there is so much of volume out there that can be connected across the globe from every place on the earth. Basically, you're taking a lot of data and it is doing it at a very very fast pace, and there is a variety of data. You name it, the information is out there, and they kind of aggregating them, putting them all together. And then also it's just a variability in terms of the race, sex, different location, what the people do, how they do things, how the medical conditions vary. These are all possible because of the big data. Then, of course, the cloud computing, putting all this information in a cloud computing. Some of the technical experts will go a little bit more details into the cloud computing rather than me. Hopefully they can highlight us about this cloud computing, how it works, what happens. What do I know is basically system has been put it at one place where it can be organized, it can be set, it can be sorted out, and then it also gives the outcome that what we might be looking for. Next slide, please. So if you look at the growth of the advancements in the AI growth, there is a significant investment both from the private sector as well from the government sector for the growth of the computing speed as well as the storage capacity. If you look from the very early 90s all the way up to 20s, it's a tremendous growth in terms of how much of data can be shared across, and then also how it can be mitigated. Mitigated means in the sense looking for the data that's really useful and then aligning in the way the company or the institution or the government was to utilize. Yeah. Next slide, please. So if you look at some of the cost, I'm going to go a little bit details into this one. Some of the cost that is associated with the healthcare. It's a direct cost and indirect cost, and some of the intangible cost. Intangible cost is basically somebody who has a medical condition cannot work or cannot do their job, and then all of a sudden then they pretty much will be on disability, where the government or the private enterprise take care of all the payment. That's a cost associated with the disability to it. Indirect cost is basically is the productivity loss that is secondary to the person who is in a hospital, who is in a medical care facility that cannot perform the work. That's an indirect cost. Looking at the direct cost is basically the medical care. You go in a conventional, whether it can be in a clinic or it can be in a hospital setting. It can also be in a places like in a rehab facilities, and also some also include part of the nursing facility nowadays. Of course, some of the nursing home in India are called as hospital. Here, in a broader sense, in hospitals, generally means where the patients do get the health care. The alternative care include like a hospice care where the person is kind of terminal, where the enterprises, or the private or the public, provide the care for them, even though that itself is also a medical cost. So these are all basically the costs that are associated in taking care of the health care of the people. Next slide, please. As you can see, this is only from the United States. A significant amount of money has been sent for the healthcare, and there is a lot of data out there saying that is it really worth spending so much of money, and the outcome is still not to the expected. Like you always look at the return on investment, even though in healthcare that's always a touchy subject, whether you really want to have a return on investment for taking care of the people, healthcare needs of the people. And then as you can see, that's the total expenses in the US, 70%. And then out of that, about 30% go for administrative work. That goes with registration, billing, background billing, getting the money back from the insurance company, stuff like that. So rest of the 70% is really a direct cost. Next slide, please. So there is a healthcare and then the healthcare coverage. Basically, healthcare is very, very easy. I will say this again. Healthcare is very, very easy. It is the healthcare delivery which is the hardest subject, because healthcare delivery includes management of the funds or the money that has to go through the system, and it has to be streamlined. And that's where most of the healthcare system faces the trouble. Even in the universal healthcare system, like in the United Kingdom as well as in Canada, they go through the same issue as well. So healthcare itself is pretty easy. Go to your doctor, go to a hospital, get the healthcare from the provider. That's the easiest part. The hardest part is the thing that happens in the background. Next slide, please. So let's look at the AI's learning curve in medicine, why it came into the play and how it all started. Many people think that in 2022, with the launch of the ChatGPT, even before that, even the Google search with the medical intent was the beginning. But this, the AI's learning really took off very rapidly from 2022. So in 2023, first study showing the AI beating the trainee in the licensing medical exam, board exam. Actually, it was a United States medical licensing exam. So they gave the same questions and everything to the computer uh, for the AI involved computer, and then the trainees, and it turned out computer did a much better job. And all of a sudden, everybody was kind of like, "Oh wow, there is something there that can be looked into in detail." AI outperformed the faculty at the New England Journal of Medicine clinical problem solving cases. They threw a bunch of medical conditions to different groups of providers, and then all of a sudden, AI did much better than compared to the providers. And then in 2024, AI is outperforming MD plus the Diadon measure of diagnostic reasoning. Means diagnostic reasoning is the holy grail of the physician, basically putting all the puzzles together: age, sex, patient's complaint, and then looking at the labs, looking at all this information, and then reasoning what could be the real medical condition this person or she or he has, and then how to mitigate it with the learning that we have done during the medical school and later by practicing, looking at the pattern. The AI is able to do that because of so much of data that it has already with the medical information. Next slide, please. So, healthcare and the productivity. This is something that most of the hospital senior leadership would always be worried about. Uh, Healthcare is probably the only industry that added technology, what you call say electronic health records, and the last productivity. Productivity was the lowest in the healthcare field. If you look at everywhere else, like all other fields has been making a good progress whenever there is a technology introduced. And it is always a big challenge in the
ലാസ്റ്റ്
healthcare
ഒന്നും ഞാൻ പറയാം അല്ലെ ഇത് എത്ര മണി വരെ 4 മണി വരെയാ
where they
4
always
മണി
try,
അല്ലെങ്കിൽ അവർക്ക് വോട്ട് ചെയ്യില്ലേ
where they always try to push against the technology, even though invariably we come around and then we will accept the other technology as needed. So okay. Can you guys hear me okay now?
Yeah.
Okay, thank you. All right,
Okay.
yeah. So there are some segments which is kind of underperforming. So healthcare is one among that, where that we tend to kind of we think we can do it all, but we struggle. So let's put it that way. Electronic health record was actually created as a way to manage the payment system. I think one of the cartoon that I mentioned about the healthcare pay and the coverage, right? This electronic health record was created for that, basically to say complexity of the patient's care and how to bill. A cardiothoracic surgeon who does a 4-vessel bypass surgery should be get at a different level of care or amount of money compared to another surgeon who probably just do an hernia surgery. So they cannot be paid at the different same thing. So this electronic health record try to create that one by making a code, different code for different diseases, and based on that, People would or the providers would get paid for the service fee. Hospitals would get, we would get a different fee. So this electronic health record was helping to mitigate, basically to find out how do you document the cases, what are all the things that you look at, what is the reasoning for doing procedure. To documentation becomes cumbersome for many healthcare providers, not just for the doctors, even for the nurses, people who work in the healthcare industry can tell you on and on and on. And if you work in a one healthcare system, then all of a sudden you go to a different healthcare system, then you have to use a different healthcare, the electronic health record. Then you have to start from the scratch all over again. The same thing whether if you work in a clinic, it does not communicate with the hospital. The information cannot be transferred from one system to another system. That's where there was a problem. In 2008, they did mitigate that one with some of the cross functionality of the different electronic health records so that they can all talk to one another. Even today, a lot of the hospital do not want to share the information from one facility to another facility to inter facility, or even across a state as different rules. I do know in India they also have electronic health record. They're also modifying a lot of stuff. They also struggle. So also in the United Kingdom. So also in the only place where they might be have a little bit of less friction is probably in Canada, where they have a pretty much a big one enterprise healthcare system that manages all the medical information. Next slide, please. What about the consumers? Do they like AI? Or if they say, are they enjoying it? Are they willing to give a try? So they actually did a study in 2022. Come to find out, lot of both the genders actually have started to like it. This likely, so if it improves the access to the doctor's appointment, yes, of course, everybody loves that one. It helps to discover the newer medications. Absolutely. Does it improve the health? That's one of the biggest thing. Of course, they would love it. Does it decreases your healthcare cost? Everybody would love it. We will see whether it's going to materialize or not. Sometimes people want certain things. That's what Steve Jobs used to say. Do not give what everybody wants. You want to give the best thing to them. So we'll see whether that's going to materialize, whether the AI is going to bring down the healthcare costs. So that is to be seen. And then it was developed with the input from the diverse communities. Obviously, the diversity and equity is a big deal here in the United States, even across the globe. And you can see in both males and females, they really want this one to be something that can be used for an innovation, affordability, and equity. Okay, so they would like to see the AI play a big role, especially in the generation AI. Next slide, please. So, clinical takeaways. So if you look at the in a variation of a survey, this was actually came out recently from Ohio, where 51% reported using the AI to make an important healthcare decisions without consulting clinician. So when it is more than 50%, you know that the thing is coming, the storm is coming, whether you like it or not. Means a lot of people are using it. Clinicians are using it to to look at the data. So, and it is only increasing. And why that matters is it's a public awareness that there is something out there that I can look up about the clinician or the hospital. They used to get a lot of the marketing mailing in the past, where the hospitals, healthcare systems would send information to the provider on about the providers to the patients in the community. Now that same information can be shared in across our platforms, and the generative AI is able to come up with their own algorithmic way of determining who is the good doctor, who is not so good doctor, who is mediocre, things like that. So AI is actually choosing the clinician for the patient already. This is the takeaway from this slide. Next slide, please. So the digital transformation as well as the generative AI are potential solution to many of the industry challenges. I think I went over that some of the biggest headache for the healthcare C-suite in a team where they always use a word called there is no mission without a margin. You want to do a lot of things, some of the healthcare systems, some of the best one want to do a lot of things, but they always look at the bottom line, which is basically the funds. If you don't have funds, then there is not a whole lot thing you can do. That's why some of the hospitals who are good also struggle because it always comes down to the margin. So they always try to figure out how we can increase the margin. This is an annual thing. Every year, every quarter, all the healthcare executives, when they meet, their first talking point is what is your margin? How are you able to do that? And they look at how exactly whether they can use the generative AI to do that. Just part. Nearly 60% of healthcare executives they want to accelerate the investment in digital transformation and generative AI. They believe it, and it is happening. I will give some of the examples how far they have gone from thinking about it to actually investing billions and billions of dollars. And then if you look at some of the top priorities, as I mentioned, it's not in the healthcare itself, but it is in the healthcare delivery. Their top priorities is still including in the claims and payment, patient support services, and the prevention management, rather than in the healthcare arena itself, which is taking care of the patient, but it is in the other administrative aspect. Taking care of the patients is going to be one on the in the horizon in a very, very rapidly progressive way. I will show some of the data. Next slide, please. So why that's a big issue is that I'm pretty sure all the healthcare, even in India, where there are so many doctors, but per capita of doctors is still low. It was low even when I was in a medical school in 1989 when I went to medical school. Even now, even though there are so many medical colleges, so many schools that came up, so many nursing school came up, healthcare staffing is still low. Some of you probably know when you go to a hospital, there will always be short staff. There is hardly any healthcare system that says we are well staffed, we are completely full, we don't need anybody anymore. I never seen that happening. So as you can see, there is a more demand for the healthcare, and there is obviously more manpower that is needed that you just cannot keep up. People like you probably can relate to how often we used to go to the doctors like in 1970s or 80s. As you can see over the decades, as progress with an advancement, a lot more people are getting into the healthcare system to take care of the healthcare needs. And then obviously there is a huge demand, and that will continue as the people starts getting older and older, which the natural cycle, there will be a lot more demand for healthcare needs. Next slide, please. So there is always a say, if you talk to a CEO, it's like, our process is the excellent, the efficient, and it's like, yeah, but you're just circling around, you're just going around the circle, you're going nowhere. So this is just another sidekick to say, do not confuse your innovations and the progress too. You're just going around the circles. You still have to go to the heart. Even though there are some innovation changes that are happening a bit, where there is a medical home, rather than you going to a hospital doing, getting certain things, some of the infusion that can be done at manage at home. So there is some progress there. Next slide, please. These are some of the big the AI impact on the healthcare. So will the AI bend the cost of the cost curve? As I mentioned very early on, cost has been going everywhere, not just even in advanced countries, even the developing and underdeveloped countries. There is a significant impact of the healthcare cost that they cannot keep up. Can this be mitigated by the AI? Can the AI increase the productivity and the digitalization? Specifically, this area is something probably is already happening in the United States and partly in the other countries as well, with digitalization of the records. You probably don't see a whole lot of the providers. They're just scribbling on the paper and then just stuff it in the chart. There are very probably less than 6 to 8% in the United States. Still, some of the providers do scribble on the papers and then put it in the chart. It's usually in part of the concierge medicine where it's usually the overall the implication for the healthcare cost is less here, because that's more of a concierge medicine care. But everywhere else, digitalization of the records is happening. And can the AI make it better? Can the AI put all these medical conditions in a different format so that anybody can click on it and it's like get the whole picture of the patient? Can the AI do and increase the access and capacity to be more than less? Can they do that? So you probably have heard of this one, like there is a huge demand for the stroke specialist and also the heart doctors. Heart doctors cannot be at everywhere all the time. Even the stroke doctors, can the innovations, can the AI can provide this input to some of the rural community hospital, rural community healthcare centers, but not involving the neurologist to put forward and give the details of the patient and come up with a rational thinking what to be done next. They can AI reduce the clinician burnout so that they can focus more on the patient care, which is basically taking the administrative aspect of it, which has happened in a lot of things already, which I will give you some of the details. Next slide, please. How are we doing with the time so far? It's about
Sir, you
40.
can continue. No problem. As
Yeah,
long as
thank you.
no problem, sir. There's no still 1 or
Thank
2 hours.
Yeah, thank you. So
Take your time.
let's look at the election greeting robot. This one I saw recently in some of the elections. I believe it was in Kerala, maybe. So where they showed one of the robot that actually went and greeted one of the first person who was standing in the line for the voting booth. So robot dressed up just like an Indian attire. Go and meet and do the things. What happens if we do the next one? Next slide, please. We also have a surgeon in Singapore operating on somebody in India, an advanced surgery in the abdomen that cannot be done by any other physician or a surgeons in that area. So he was able to do that one basically by totally remotely, which DVNC, some of the uh, the system has been doing is now this is so much advanced, so much precise. They actually have a better outcome. Can the surgeon who has done this one, can the AI start doing this? Can the AI learn how to do this precision cutting edge medicine actually happening without involvement of the surgeon? So think about that one in the future. Next slide, please. So if you look at some of this healthcare system that are actually have put a lot of investment in the AI, and specifically the generative AI. I'm not talking about the clunky AI about the audio visual things and stuff like that, but actually a real AI which can actually make an impact in the healthcare. You name any healthcare system, some of the big ones, including the Rush, Memorial Hermann in the Texas, one of the biggest state. Some of them are thinking about it. They are usually the community hospitals, smaller, roles. And if you look at the, places like MD Anderson, the biggest cancer center, they have done so much advancement in the AI technology. If you just say it, you're like, oh my God. So what the doctors is gonna do now? So they have done way advanced, and even some of the places like the Mayo healthcare system, they have done a significant advancement in terms of the AI in the clinical arena, not just in the administrative arena. I want to re-emphasize it's in the clinical arena of how AI can give a better advice or better decision making than the physician, and they're experimenting, and some of them data is actually very good. Next slide, please. This is one example that I attended one of the talk at the Society of Hospital Medicine recently, where they talked about some of the AI that is already completely put in place. Every clinician has access to a AI scribe. Means in the past, if you work in a hospital and then if you see a lot of patients, one of the biggest challenges was the physician says, we just cannot keep on typing and cannot, say things. And then somebody would take a note for you and then they will go after the patients. See, I have done that one in the emergency room so many years. Somebody will run behind me with a computer holding, carrying and typing as I say, this patient is XYZ. Now it's all AI. They have one small like clipboard that they attach to their dress, or even in their phone that has an app. You go and interact with the patient, do what you need to do. Everything gets recorded and synthesized in a nice format that you can go back and then re-edit if you need to. Otherwise, it pretty much makes it pretty much stand alone, and it can be put in the electronic health record. Every clinician has an access to AI charts, summarization, and AI drops up discharge summary. Think about this. Discharge summary, right? It takes a lot of time for the physician to go through, specifically if the patient stays for more than 3 days in a hospital. If they come for a chest pain, you saw the patient, you took care of it, cardiac cath was done, they had a stent, no stent, they put some medication, easy peasy. But not every patient is easy peasy. That's why they come to the hospital, where they stay for several days. So many things happens, even though it might seem like a minute thing that happens, but it has to be recorded, right? So when it get recorded, and then physicians may not remember everything when he was doing the dictation or the typing or mentioning at the time of the discharge. What happens if the AI can look at all the events that happen in the hospital and summarizes it for the providers and say, yep, this is what happened. I remember all these things. Now sign up on this one. This is where some of the company that I work with, that they review all the information that happens in the hospital for the billing purpose, say whether all these things did happen, and this is how much the insurance has to pay because of the higher complexity of the care. Let's look at the patient facing the AI within the patient portal. Means when they go into the patient portal, they want to look at the bill or they want to look at what happened in the hospital. Patient can see, and it is all done by the AI. Back office support, as I mentioned, billing and revenue cycle, prior authorization, and even the patient communication, even creating the notes, even creating some of the documentation that goes back to the patient is pretty much done by the AI at the University of California in San Francisco. Clinical decision support gaining a momentum and the introduction. This is where a lot of the healthcare providers are giving a pushback. Can the AI making a clinical decision support, in the upfront, basically saying, in other words, a patient, age 50 years old, come to the hospital with a chest pain. We used to do the what class a triaging and then determine what kind of workup that needs to happen to that patient. Ideally, the clinician should see the patient, evaluate the patient, then put the orders. Then certain orders should be done in a methodical way to prevent escalation of the cost. But now they're thinking whether the AI can actually generate, depending on the age and depending on the complexity of the patient, what all things that should happen automatically, even without involvement of the clinician. This is where the friction is happening. And I'm pretty sure it's going to get sorted out. And then we will discuss that one in the coming slides. So as I mentioned, it's a clinical decision support that is gaining the momentum, but also facing some hurdles because of the different groups, different providers having a different thought process of how it should happen or how it should be implemented. Next slide, please. So right now, these are all the areas where the AI is actually making an impact, whether it could be in the diagnostic and medical imaging pathology. Recently, one of my friend at the MD Anderson, they created reading the pathology slides by AI in Bangalore. So they have a company that doing that one. Of course, here is pretty much happening, and some of them has to be read or overread by the clinician. Predictive analytics, in other words, patient with XYZ medical condition, what are the chances of this patient not able to leave the hospital or making a good progress? It gives a predictive analysis. Personalized medicine. Patients, some of the executives use this personalized medicine wherein it is kind of suited for certain persons with a different medical condition that gives an input of what should be the best option for that one. Virtual health assistant, basically what I mentioned about the like the tele cardiology, tele neurology, or the stroke providers, not really involving the physicians or the clinician, but mainly the AI is doing that. Natural language processing, which is basically the scribe thing that I went over earlier. And then, of course, the robotic surgery. This robotic surgery used to be mundane, like, a provider has to be there to do this. But nowadays, they actually have done some experiment where the robot does all the procedures. There is a big investment in that one, in this arena, where the expense of the clinician or the surgeon. This is where there is also a little bit of friction between the clinicians and the AI implementation in some of the healthcare system. Remote monitoring and telehealth, that's been going on. So they used to do this one in a generic way. You would connect patient to a telemetry monitoring, but now there's an analysis that is happening in the background that give a predictive analytics that spill out what are the chances of this patient deteriorating within the next, say, 12 hours or 24 hours. Drug discovery and development used to take about 10 to 20 years, but now it has been so advanced within the 1 to 3 years time. Think about medication that comes in, develop, implemented, put into use used to take so many years, but now it's within a matter of year or so. A new drugs, and that is because of the predictive analysis. What are the chances of this drug become successful or not? Clinical trials, of course, this is also has been going in for a while, but now there is a generative AI that can actually make an informed decision whether it is going to be successful or not. Fraud detection, this is another thing that you might have seen several big headlines where clinicians, which they're not supposed to, which they should not, because we're in a highly delicate what do you call as a arena of taking care of the patients. Some people do overcharge, or some people do undercharge, and they charge for the services that they did not provide, which is more unethical, which I'm going to cover in some of the discussion in the next topic. The AI can actually root it out. It can actually see, hey, this patient was never seen. This patient never came to the clinic. How is this billing is happening when there is no care that actually happened to this patient? Actually, the AI is able to pick those things up. This is done more on the insurance side, or if it is a government payer, they're also looking at into that, involving the AI there. Population health management, this is basically about looking at the population, which population in particular area has a certain type of cancer. Can the AI make a predictive analysis of what kind of resources that are needed to send it to that place so that they can mitigate it? Say, for example, if there is a breakout of measles in certain location, can the AI help with what are the range of options that are available that can be sent to that area to mitigate, so that it can be contained in a particular location rather than becomes spread out? One of the example would be something like a COVID. Can the AI predict this one way in advance so that it does not become a global phenomena? Next slide, please. So the transformative role is there, as I mentioned. Basically, it's everywhere, and I'm actually surprised that it is growing so fast in a different arena, including in the public health arena as well. Next slide, please. So let's take some of the actual real thing that is actually happening in the diagnostic and medical imaging and the pathology. Basically, computer reading, some of the scans. This is mundane nowadays. That a lot of the let's take one step backwards. One of the things that was happening, at least in the United States that I know, was people used to get mammography, and then mammography reading takes longer time because radiologists were not enough of capacity to manage all the imaging, like the X-rays, the CAT scan, the MRI. So mammography used to take a little bit of backstage. In other words, it would take a longer time for them to read. Then they determined, a lot of people getting the mammogram, not having the results, and some of them are missing the results, missing the diagnosis. the mammography saying that there is no cancer, but then the patient actually did had a cancer that was kind of not picked up. And then the death of some of the big celebrities, and all of a sudden they started looking at the pattern and say whether we can do something with the AI to mitigate the staffing issue. And then all of a sudden they come to find out it's actually a good deal. A lot of this imaging can be done with the AI, and then that can be seen by the ultimately it has to be signed off by a clinician for the billing purpose and for the what do you call for the risk analysis as well as the risk taking. A clinician must still sign off on it. That role of the clinician always had to sign off on it. We will discuss in the ethical issue in the next topic, but right now that's how it has been set up. If the government do make that much loose, AI can read and then take a risk with the reading, and then that's what we're gonna accept. That is something that has to happen with the big government has to make that kind of decision. But right now, clinician has to still sign up on it. So if you get like 100 X-rays that's been read by the AI, and then maybe 10% of them can be reviewed by the clinician and says concur or don't concur, or if this is the changes that has to be added to the note, that can be done. And apparently AI does a much better job in picking up all these mammography reading much better than the clinician. So what about the pathology? Come to find out, next slide please. Next slide please, thank you. Okay, so the pathology. So what they used to do, at least when we went to medical school, they would take a tissue specimen, put it on the slide, put all kind of dyes, and then determine what is the real pathology is. Obviously, a more experienced pathologist would be so good at looking at the slide. It's like, oh yeah, this is a lymphoma. Oh yeah, this is a Hodgkin's lymphoma, or a different malignancy, or it's a normal tissue, that kind of thing. What if the AI, which it is already doing, and it is getting better at it, better, more, much more in a robust way than the clinician, and say, this is what it is, and this is the real diagnosis. What happens? You're talking about time saving from that clinician time that the AI actually gives a real throughput. Same thing with the microbiologist too, that can determine what is the real culprit in some of the infectious process as well. So some of these an image analysis that the data is out there. The data is already there. There is a big data about how the cells looks and then how it needs to be picked up can be done by the AI. And this is one of the chopping block. I'm using a rude word here, but that's what it is in the healthcare industry. So at least in the healthcare industry, chopping block of whether this can be done by a certified pathologist versus the AI can do a better job. Next slide, please. So they actually did a study. This was in May 2024. A broad range of countries, different countries, 152,000 slide images, many diseases, predominantly cancers. That's where most of the big bucks, right? The mean sensitivity of 96.3% and mean specificity of 93%. Which is better than the clinician. So, which is kind of eye opener for a lot of the things, like it's like, oh my God, this is actually doing a much better job than the clinician who takes, I mean, not that the clinician don't do, but they do take a lot of time to, to develop that memory power. Like you look at the slide and say, oh yeah, this is the lymphoma, this is the type of lymphoma. And this AI can go even step further and says it is exactly this specific type that is actually that can be picked up on the AI. Next slide, please. How about the predictive analytics? How does this help with the clinician as well as the administrator? How about the company? Same thing. Predictive summary. Patients with more than 3 to 5 medical conditions have a higher risk for complications in the hospital. Whether it could be from the fall, it could be from the infection that they can develop. For some of the clinicians out there, they probably know this. Hospitals, even though it's supposed to be the safest place, sometimes even the doctor says, unless you're really sick, don't come to the hospital because you're likely to catch some other infections, likely to have some other complications which is not related to your condition. But hospitals are the places where you actually has to get a care because that's how it is done. So if you look at all the, some of the summary here, basically it sums up and says, what are the chances this patient with these medical conditions likely to have a heart attack? Whether what kind of procedure was done, it it pretty much summarizes this so quickly and then gives and throughput into the code that can be used for billing purposes to pay. X number of medical condition, X number of procedures done, what was done, and then how much should be paid to the hospital or the clinician service. Predictive analysis. Next slide, please. Voice over the text. This is the voice that I mentioned that most of the clinicians has been using this one, except in some small facilities where they don't use it. It serves two purposes. So if you go to any doctors in the past, at least in the US, I know even in India, it used to be that they would put you behind the computers. Computer would interface between you and the patient. And then you pretty much spend, a lot of time trying to document what the patient is saying rather than really focusing and really kind of getting involved in what you call as a active listening to the patient, because this was an administrative burden you must do. As I mentioned, there is no mission without a margin. If you don't bill properly, you're not going to get paid properly. If you don't get paid properly, then the hospital is not going to make money. So this is an administrative role that you must do. So clinician would sit and with a computer between the patient and then try to document everything what the patient is saying. What happens if we just put a clip into your into your code, and then just sit with the patient, talk with the patient, do an examination, everything gets recorded. Everything gets recorded and it makes a summary. Every room also catches any information too. That is a double-edged sword. You cannot use any bad words. You cannot use any abusive words. I mean, there is an option to delete those kind of, a noise that really does not have to be in the chart for a discussion, but everything else does. That pretty much removed the computer from the patient's room where they can actually interact with the clinician. This is what I was going to say. Next slide, please. And this system has improved. I remember we used to use what calls a dragon system. It would not recognize if you have an accent like me, or if you're from a different country, it would not recognize. It has to be a proper English that you're supposed to say, the way it's supposed to be said, then only it would recognize. But now it has modified so much. Anybody can say thing and it will recognize it and it will modify it, and it tells in a different languages too. So that's a good the advantages with the AI. So let's look at some of the remote monitoring, as I mentioned in some of the involvement of the AI. Remote monitoring. One of the facility that I visited when I was doing a fellowship for the American College of Healthcare Executives was in Texas Memorial Hermann Hospital, where they put a remote monitoring sensor that captures a patient's oxygen level, heart rate level, blood pressure level, breathing level, everything, including the movement of the perspiration of the skin, and it will spill out the data for the alertness to the nurses as well as to the clinician. Is this patient is going to have any complications within the next 12 hours? What are the trend? It will also pick up some of the data associated with it, with some of the labs that were drawn, and then it predicts whether this patient is going to crash within the next 4 to 6 hours or 12 hours, and what are the things that needs to happen. Remote monitoring. It also tells about the sleep cycle, activity, everything. So this BioButton Vitals is one of the innovative technology that's happening. Next slide, please. And the cost of this, I mean, it's a big cost, but over a period of time, the cost should come down. I have seen this one. Some of you probably have seen this one too in India as well, where the built-in sensors, like they can actually read the EKG. I have seen in the ER like 3 or 4 people coming to the ER and say, my phone says I have AFib. I says, what is AFib? I don't know what it is. You tell me. So it actually tell them that there is an AFib, you need to seek a medical attention. Now, is this overdoing on the healthcare spending? I don't think part is there, but it also picks up the thing that were not being picked up before. Unless if you're not, wearing this one, this probably would not have been picked up. Same thing with the great monitoring of diabetes. How often you see, I'm pretty sure that in India is still in the early stages of it, of having this glucose monitor. You put a patch onto your arm. My son uses it actually. He has diabetes. He uses this one every 14 days. You put a patch, and then you have a system that recognizes how much is the blood sugar, and it recognizes continuously. They don't have to prick their skin, none of those. And it also tells what should be the accurate numbers, and that has been significant change from what we used to do and what the AI can do with the monitoring of the patient. This same data goes to his endocrinologist, my son's endocrinologist. They can also see the spread out. Obviously, they don't have to watch it every hour, every month or something, but they will get data whether the diabetes of this person is well under control or not. Obviously, well-controlled diabetes prevent future complications, and that's how the AI has been put into place. Next slide, please. I'm not sure what is the scribble says, but I see some scribble on the slide. Anyway, so again, you can take a patient and then look at all the information of their breathing, how it is, and then it spills out in a single patient view. One nurse can monitor about ideally about 4 to 6 patients on the floor. In the intensive care unit is usually one or two patients, wherein they focus so much of information in the critical phase, and they can focus on the real care rather than just monitoring. The monitoring can be done by the AI. Next slide, please. So think about how it actually helps in the operations of the healthcare delivery. So one of the system that they've implemented is with a setup like a camera that has been set up in the operating room. It tells all the movements, and it gives an ambient intelligence in the operating room. how often the patient was brought in and taken out, what is the time gap, is there a time delay, is there a what is the atmosphere is happening, is there any blockage of the movement of, so it recognizes and it spills out how to efficiently manage the operating room. Of course, it's almost like you have an aeroplane that is sitting in the airport is not going to make money. When the airplane, when it's in the air, is the only time that it actually makes money, not when it is parked. Same thing with the operating room too. The turnover in the operating room is the one that brings the revenue, because you're going to be able to move the patient, get that one efficiently. This is where it is done. Imagine you're putting a person there just to monitoring it versus a system doing this one. This is an obviously a great way of monitoring the throughput in the operating room. Next slide, please.
Sir, let me stop sharing, then I will again come back because that lines is still there.
Yeah,
Just
thank
1
you.
second.
Sure thing. Yeah. I hope somebody is taking some questions on the side, and then I will try to answer them. And then hopefully alert me maybe about 25 minutes or so ahead, so that we'll have a good time for discussion.
Yeah, sure, sure.
But excellent. Thank you. Next slide, please. So, human versus ambient intelligence latency, as I mentioned, the nurses, which usually keeps track of all the throughput from the operating room, they will recognize this is actually a real example, uh, um, basically to say how many minutes is saved with an ambient intelligence technology versus human information comes a little bit late, means you document, you review, and then every week in a meeting or a monthly meeting you will say, oh, we could have done this, but this OR was empty, nothing was happening there, we could have used that operating room to do this small procedure, versus waiting for this. And so it's almost like matching the surgeons availability, staffing availability, and also the equipment availability. They can all be matched. So this is a great way of improving the throughput. Next slide, please. So also the management of the patients. So if you look at the management, it gives so much of data. Sometimes, we always worry, are we getting too much of data? That's always a question that some clinicians do we really need to know so much of information about things? But for the AI, that's how it predicts. There is so much of data about the person that they can put the what do you call it, a missing dot, and then say, yep, these are all the things, these are all the signs that the patient is exhibiting, and patient is going to likely to have a bad outcome. Can you do something about this? And these are all the options. So it actually spits out what are the thing that can be done. In the background, you can actually see even the remote monitoring of the patients, the pain level, whether he's comfortable or not. These are the technologies already put in place in the United States in several hospitals. Next slide, please. So if you look at some of the advanced people, I'm pretty sure you will get a lot more information from some of the technological aspect of this one, some of the innovative like the AI personnel who are actually involved in it. They can talk a little bit more about it, but these are some of the advanced technology that's been put in place in clinical documentation. Nuance, which is basically the dragon that used to make all of the spaces. In the clinical documentation also, they're doing, the Philips has been doing it for a long time in the patient automation, as well as the patient engagement communication, different the technology companies that are making investment, corporate services, including ChatGPT, and internal operations. One that I know is the Gentum. Different companies are investing a whole art. That means AI is touching every aspect of the healthcare, starting from even before the patient comes into the healthcare system. They're putting all the information way ahead of time, so that when the patient do come to the hospital or come to the clinician or clinician's office or into the ambulatory surgery, we already have set up the system, including how to get the money back for the services in a very quick way. The turnaround time for billing in the United States used to be what we call as a benchmark, about 6 weeks. So you provide the service, within the next 6 weeks, you're expected to get paid. But nowadays, it's happening within weeks. The insurance payers are the payers, even though there are government payers, private payers, even they have been proactive, getting all this data so advanced. In the past, you would see a patient, you would bill, and then you would send that bill either by faxing or by scanning, and then on the insurance company will look at all those code, and they will put a check mark and then say, yeah, this service happened, needs to be paid. Then it go to a check department, and they would send bunch of checks to the doctor's office or to the hospital. Not anymore. Everything is pretty much done electronic. I hope it is the same thing even in the India also, where you will see the turnaround time is so quick. Money in hand is better than money on the table. Let's put it that way. Next slide, please. So you can also see from the performance to the delivery, right? So some people question, is this AI hype is real? And all the experts that I spoke with, all the experts that I listened to says it is real, it is happening. You just have to get on board. So what does that mean? The demand for the AI is exponential nowadays. It's not only from the some of the examples that I gave you from the patient perspective, as well from the clinician perspective, as well from the administrative perspective, as well as from the insurance perspective. This whole the arena has been pretty much is engaged with the AI. And they do think that it is AI is a panacea. It might turn out to be that way, but you see the growth of the AI compared to all other the technology that we are seeing, like either TikTok or Meta or Facebook, all of those. If you look at the ChatGPT, how fast it spread so quickly in the healthcare arena, it is happening even much faster pace. Next slide, please. Real world outcomes across specialties. So obviously, whenever we put something in place, we want to see the outcome. Is it really happening? If you look at the survey of those, some of the patient satisfaction scores are going high, because you are taking away the computers between the provider and the interaction. What about the return on investment is actually pretty significant. Not too many people will tell you that. People who have invested in the AI, in the advanced technology, are seeing a lot of returns already. That is because they're taking away a lot of the administrative burden taken away. When it comes into the clinical arena, that it to be seen. I want to re-emphasize this one. Right now, the return on investment is in the administrative arena. means documentation, making a throughput much faster, or recognizing some of the clinical signs early on so that the clinician can make a decision, more of a supportive role, but not really into the care itself. But that's going to happen eventually, where the AI will actually might be able to override some of the clinicians' the thought process is like, hey, no, this one seems like something different because this patient has XYZ that you weren't aware of. You weren't not, mentioning or involved in your decision making. So overall, the outcomes are actually good, even in the very early phase of the system. Next slide, please. So this is what many people are predicting, the smart hospitals of the future. Okay, so wherein patient choose the appointment rather than the system choosing the appointment, because the appointments will be already opened up their system. Patient can log in and get into the system. That's what we call the patient portal. Then also you can self check in. You have an insurance card, you have an insurance information. AI already has that information as well. If you just enter your name and your social security number and the date of birth, pretty much your data is out there. I'm pretty much sure the same thing in the India. I'm sure some of the people is going to give me a little bit more detail, specifically with the Aadhaar card, with so much of information, with an integration of the Aadhaar card, patient's information, and the Aadhaar card and the insurance information, whether it can be integrated in a very, very quick way, wherein they can self check in. There is nobody there to kind of welcome you, and it's like, yeah, can you check in here, give me all the information all over again. No need for that. Then clinical financial knowledge, as I mentioned, for the billing purpose. um, Call centers, pretty much, you make a phone call nowadays, pretty much managed by AI. Whether it's a bank, which they introduced long time ago, even the hospital nowadays, AI is managing a lot of the phone call. um, Basically, 5 digital basically means recognizing which hospital has the quickest way of getting to the care. So say you have an emergency situation, you have 5 hospitals surrounding you, and then it can tell you which hospitals likely has a very quick time turnaround for you to go there, rather than you go to the one hospital that has a wait time of 8 hours versus wait time of less than 2 hours. Smart rooms, again, with some of the smart technology that has been put in with an ambient temperature monitoring, vitals monitoring, again, voice over the type, that is pretty much it's a done deal. There'll be a switch there that pretty much automatically records everything. Predictive and the proactive AI, ambient intelligence, we covered some of the information early on. Of course, the service robotics. So some of the hospitals, specifically the place that I worked, it's in the Veterans Affairs, they call the red coat help. Red coat help means they usually carry a driving in a small car or a cart. They will take from one place to another place so that you can get all the care in a different location, get the blood drawn, get an imaging done, and whatnot. Now the robot can do that. In fact, the system that where I worked, a robot can bring the medication from the pharmacy to the patient's location. Think about that. So nobody is there to send. There is no tubing system. There is no mismanagement. It actually been sorted out from the beginning itself, so that there is no manual. People doesn't have to open the bottle and put all the medications. Everything is already done by the AI and brought to the patient's location. Remote monitoring that we talked about, and of course, multimodal education. Multimodal education means putting the AI into the early education system of the clinicians who are graduating new. So this has been an emphasis that what the way that we were trained, you touching the patient and then doing a dissection on the patients. Nowadays they do a lot more on the model. They create a 3D model and look at how the anatomy works, how the physiology works, and the learning is different. Professor Sogol, surgeon, do we have enough of time for discussion, or are we good with the
Sir, you
time?
can continue. You can take another 1 more hour, including
Thank you.
discussion.
Thank you. Next slide, please. So again, whenever we talk about the future of the AI, obviously it comes with a lot of cost. That cost has to do with redesigning some of this. Some of them can be what we call as a retrofitted, means you have already a operating room, you put all this ambient technology possible to make the AI more um, uh, user friendly. Sometimes you had to do a lot of redesigning the physical space itself. There are a lot of space in the hospital, what I call as a brick wall, or some of them are useless. There is hardly any use for certain things in a hospital. You may not be able to retrofit some of the new technology that you're bringing in. That's where you may have to put an investment for the new physical space. And then, of course, decentralization of the care means not everybody has to go to a one location to pick up a medication. It can be dispensed. Even now, even in India, um, when the patient get discharged, there is a dispensary in the hospital that everybody goes there and stand in a line to get those medication. Can you put it in a different areas so that with your card or whatever that you come up with a plan, they go and scan, your medication is ready, you take it at home. There is no wastage of the time. Increased demand for IT infrastructure. This is, I do not have to go more details. Billions and billions of dollars has been invested, especially for some of the big IT corridors. And it is happening in all states, vertical as a data centers, which even in India is really picking up in a very fast pace, because you need a lot more space for the predictive analytics to kind of really make it to happen. Technological aspect, I'm sure we have a lot of panel who can go a little bit more details on that. And of course, adaptation of the smart technology comes with education, and then how exactly to put XYZ thing, the AI might be able to help us out in that regard. Next slide, please. Again, investment, a lot of investment. This is where earlier I mentioned some of the return on investment. Is it going to happen that quickly, or it's going to take some time? Some of the incremental return on investment, at least from the hospitals like Memorial Hermann in Texas, has been pretty good. Whatever they're investing, they're actually getting this one in return. Whether it could be in the smart patient room, which they actually have an experimental area that they actually do conduct all these experiment before they put into use. So they do what calls a mini lab experiment before they put it to use. Telemedicine suite that can actually accommodate so many patients at a different timing, and then based on the capacity management. Again, pharmacy system I just went over. Instead of so many people standing in a line, can this be automated in the background, and it can dispense at a different areas rather than everything at one place. Advanced imaging diagnostic centers, which does exclusively certain things, and then you will actually get the results right there and then. In energy efficient infrastructure, and then of course navigating system. How many of us go to a hospital, can't figure out where to go, what to do? This is a real problem. Even if we get advancement, I do not know if we can be get that place. Like the only thing that I sometimes use is my the phone, like whenever you walk from a place to place and stuff like that. But within the hospital system, they have to make it more easier for the patient. Next slide, please. Um, so the virtual reality as well as the augmentative reality, this is where it is a lot more put in place in medical education, especially the virtual reality as well as the augmented we are not talking about the games that some of the people use with the glasses, this and that, but this is more for the medical education. A lot of the technology has been put in place here, including ultrasound technology, wherein you train certain, group of doctors or the clinicians, and then you actually do an augmentative technology for the help. In the past, it used to be on some humans. You would have a person sitting there and people doing the ultrasound on that person, 8 to 10 people at a time, versus now with a virtual reality. Supply chain. Thinking about supply chain and the logistics, right? So I attended one of the conference at the University of Chicago. University of Chicago is a big healthcare system. They have several hospitals. They use the AI for the logistics. Think about that. Logistics to see what is the demand prediction for hospital supplies, whether it could be arterial line or a central line, or the supplies like how much of bandages you would need for that day. You will be able to determine that one, and this AI is able to spill out how much they actually need so that they don't have to have a big space. Anil, could you please turn off your phone, please? If they can mute the audio, and then I can come back again.
Admin, please mute them.
Anil GS, yep. Thank you. Thank you. Can you guys hear me okay? All right, yep. So, okay, and waiting. Okay, so so what they did was with the AI, they were able to determine how much of logistical supplies they need, how much they need to order that one in advance, how much they need to have in capacity, whether they're over capacity, can they lend it to another healthcare system if there is a demand. They actually experimented this one during the, believe it or not, during COVID time, where there was a lack of resources of the ventilators, right? Some hospitals had so many ventilators, but they did not need, and some of the places really needed the ventilator that they did not need, that they did not have. So they were able to send those things using this logistics. So think about how the AI can actually make a significant difference in terms of logistical problems of the hospitals. Also the infection control, right? So the AI can actually predict where the location of the infection might be starting from with the technology that they're coming up with. It is insane. Whether the cleaning was done properly or not, they might be able to smell it out and then say whether it is done right or not, and the infection control within the hospitals can be managed. Same with the patient engagement and the communication that we talked about earlier. Some of the green design, this has been going on in some of the places like in Hong Kong and even China, and also in places like in Singapore. They're designing the hospital in a totally revolutionary mindset, almost like a healing place to say, and then with an adoption of the AI to that one. Community wellness spaces. This is something that we don't talk much often. Like, can the AI predict the uneventful event that should not happen in places like in a gym? Can pick up some of the ambient location. It almost seems like creepy, but it can help. Patients with XYZ condition go to run on a treadmill. Can it predict the chances of him falling and getting hurt? This is where the community wellness space is, where the AI might be able to help us out. Next slide, please. So let's look at one of the things that what the AI can do for the clinician. We call it as de-skilling. De-skilling is things that you don't do very frequently, you tend to forget. You learn a lot of things. Who does algebra now at this age that what you learned in your 8th grade or 10th grade? You don't, unless you keep on using it. So this is one of the example with the Air France flight 447, I believe in 2009. So they came up with this new technology in the aviation. They brought the new computer system for help the pilots to navigate, and it has a feature of the autopilot option. Everybody thought this autopilot option was so good, so great in the experimental setting, and some of the navigation on that day was not good, and the system failed. Means the AI system failed or the navigation system failed, and the pilots did not know how to operate that. They did not know how to take over that and manage it. And that was a big disaster with a lot of lives. So that is a de-skilling in aviation. Next slide, please. What happens with the de-skilling in medicine? So there was actually a study out there in the Lancet of GI and hepatology. They had bunch of colonoscopies that were done by the gastroenterologist. They were all doing themselves in one pattern. Then they put an AI technology to help them to assist. That is, it would recognize, the AI would recognize whether it's a polyp, whether it is cancerous, precancerous, bleeding lesion. It would help them out. So they did an experiment for about 3 months or so, with the AI helping the clinician to look at the lesion and do the biopsy. After 3 months, they took the AI software away and let them do the procedure themselves the way they used to do. Several of them failed. And that is called de-skilling. You would lose the thing that you learn with your skill, and all of a sudden we have a big problem. And then it tend to cause us more problem. Now you're depending on the AI to help you, and all of a sudden you take the AI away, and then you also lost your own skills. This is the biggest issue that some of our clinicians partners are worried about. Next slide, please. So this is the thing that a lot of people are concerned about. Will it affect the health care, which is basically the arena between the clinician and the patient, versus it's the healthcare delivery, the overall spectrum of the care? When it becomes more intrusive, specifically when it starts intruding into the arena of the human loop, that's where the challenge is going to be. The friction is going to be. Next slide, please. This is called the human loop. Okay. So if the AI is correct about 50% of the time or the half of the time, AI is going to be useless and won't be employed. Next slide, please. If the AI is correct 100% of the time, AI will be accepted everywhere. Humans will be ultimately taken off the loop. Let me re-emphasize that one. Humans will be taken off the loop if the AI becomes 100% accurate all the time. Next slide, please. One slide backwards. Thank you. If the AI is correct about 70 to 99% of the time, humans will be tasked with being only safety bulwarks. What does that mean? This is where I think we're going to land up in, at least for the next couple of decades. AI does a lot of the things, and then a person, a clinician who is experienced in that field will be able to sign off and look at it and then mitigate if there is any risk. Some people say healthcare is personal, healthcare is local, and the AI can come in between that. And this is where the human touch versus the machine touch is going to make a play. And that's what everybody is kind of leaning into the middle ground. That's where it is going to happen. Next slide, please. So a lot of people actually would talk about this. This is an uncomfortable space, but that is the reality. Okay. So some of the job displacement theory that everybody is worried about, right? So if you go back to the internet bubble, everybody was worried that internet is going to take over everything and everybody will not have no job. Come to find out, it actually made a lot more jobs. It created a lot more. It basically has to shift, and this is where most likely that's what's going to happen. If the many patients with a similar and straightforward clinical issues, little need for physical exam, patients usually have a minimal psychological and logistical complexities. Jobs like pathologist and radiologist would be on the chopping block. Even the dermatologist too. And in between is you can see on the left side most replaceable, and the other one is the least replaceable on the right side. If there is a complex teamwork formation and engagement is needed, and if there is any procedures that are very complex, most of the surgeons are very good at that. Even some of the hospitalists who manages the patients is a bit complex, where the AI may not be able to completely replace that, because I always come back to the human touch, and it always comes back to the. So how often you see a pathologist come and talking to you in the patient's clinical arena? None, right? How often you see the radiologist, unless if they're coming and doing a procedure on you, you actually interact with the patient? Not much, right? So that's why that's on the left side, which is most replaceable to least replaceable, wherein an interaction has to happen before the risk benefit analysis is done, and then you go under the knife for a procedure or for some kind of event that has to happen. Next slide, please. So again, we talked about this one very early on, and then let's touch on the social determinants of healthcare, social determinants of health in the healthcare. Social determinants is basically an extension of the medical care. whether the patient has enough of food, whether they have a transportation, whether they have some caregivers at home that they can manage the medication. These are the things that are traditionally not used to be the part of the medical care is getting encroached upon, because we know what we do as a medical care is only 20%. Rest of the health is determined by social determinant of health, where the patient was born, what their family status, what is their outcomes, what is their understanding of the literacy. All this determines the healthcare outcome of a patient. So what we do is only 20%. So this social determinants aspect is really getting into the healthcare, because if you don't fix that one, then you really cannot take care of the patients properly. They're going to go through this what you call as a churning. They come to the hospital, then they'll come back to the hospital, then they'll come back to the hospital with the same problem. And it is not because of the medication. It's not because of that they don't get the medication, but it because of so many other things that are outside the hospital, or clinician role, or the clinic role that has to be addressed. Question is, will the AI help and mitigate those social determinants of healthcare is one of the biggest future discussions. Next slide, please. To wrap it up, let's look at where are we heading with artificial intelligence. Is it going to make a difference? I do believe so. It's it's almost like the train left the station. All that you need to do is get onto it. Otherwise, you're gonna be left behind. Or the horse left the barn already. So you need to jump onto the horse. When it will impact you, your patient and healthcare industry, it is already impacting in a tremendous way. And a lot of some are positive, some are not. Some of the folks that I speak with, they're saying that I make a phone call to make an appointment, and this system is making me go around, go around, go around. They don't like it. That's usually the nuance. Hopefully, those things can be fixed. And this is my takeaway. When there is uncertainty, there is an opportunity. That means this AI thing, which started very early on, a couple of years ago, is going very, very fast. Question is whether it's going to do everything right, or we're going to get something wrong that needs to get a course correction. This is the thing happening in the government level, what you call as a job replacement. What will happen if the AI actually does a lot of this clinical work? And then what? What's going to happen? What happened to the nurses? What happened to the anesthetist? What happened to the different group? Is the patient itself able to manage all these things? Will they? How much is the literacy of the patients who can manage this? I mean, you have seen, heard doctors prescribe a medication. Nearly about 60% will actually take the medication, 40% don't take the medication. And even if they take it, they don't complete the whole course. And even when they travel from one place to another place, they don't carry the medication. Then the complication happen. So this is where the issue of how much AI can do in the healthcare arena. Next slide, please. And then we'll cover the AI in healthcare and ethical concerns in my next talk tomorrow. And then I will open up for questions. Thank you.
Now you may ask questions.
If there is any questions on the chart that we had so far, if anybody wants to bring it up, please do so.
Please unmute yourself and you can ask questions. So one question from my side, I've seen that accelerometer. So what type of data you are getting there, sir?
The data is basically the patient's information comparing with the other hospitals surrounding the area. Like basically it gives some information about what is the predictive analysis of that, the data. It could be patient's pertinent information versus sometimes the AI gives so much of information. You may have to think whether is this data is really needed or not. So that's where the clinician may have to make it, the difference of selecting whether it is needed or not.
Okay, doctor.
And some of the information that the government is actually looking at is whether they can, what they call it as, lose the purse string. So right now the purse string is, you as a clinician should have a license and you have an authority to prescribe. You also, because you're a clinician, you're licensed, you also take a risk. The risk is if you do XYZ wrong, you pay XYZ. What happens if the AI is coming between you and your patient, making a decision, but the AI is not taking that risk? And we will cover a little bit more in the ethical issues, but this is a concern right now. Question is, can the government loosen that up and says, since the AI accuracy is like 97, 98%, then AI is not liable. Then the patient has to take the risk in getting this care that was delivered through the AI. So this is a big topic in the discussion. Thank you.
Sir, there was another question in the chat box asking for the PowerPoint presentation, whether it can be shared with the participants, yes or no?
Absolutely. Yep.
So for all registered participants, we will share the presentation.
I will send the updated one that's a little bit more robust. I will send that one and it can be shared.
Yes, yes, yes. Meanwhile, everyone, maybe before ending the session, we may ask everyone to come on video so that you will have a photo session. So please continue with your questions, please. Or put it in the chat box, we'll pick up. Dr. Suresh, sir, would you like to ask anything? You can unmute and you can ask. Beta, Narayan, you want to ask? I think they're all coming
Good
for.
question. There has to be some questions.
Yeah, there must be a lot of questions.
Again, don't be afraid to ask questions and don't think the questions are stupid. In fact, the questions that you might be asking has also been thought out by other people. It's like, thank God that person asked that question. So there is nothing like stupid questions. Yeah.
Hello, sir.
Right.
Yes, Dr.
I want
Sandeep.
to ask one question. That in some emergency cases, is the AI support systems will be available or not? In emergency situation.
Absolutely, they are reliable. They are reliable. It is true. They actually can have a better outcome. Of course, you are the one who has to do the procedure. You are the one who has to do this thing, but it can actually pick up the sepsis way ahead of we ordering all the tests. With all the information that is out there in the system about the patients, comorbid conditions, and all of those, all of a sudden, it actually gives you a predictive analysis like way ahead of you thinking about it. It is very helpful.
Oh, okay, sir. So
This
in
is
case of any emergency situation, it will be reliable.
Yes,
Oh,
yes,
okay.
and there is a lot of experiment is also going on in several hospitals where they're actually putting the AI in parallel with the provider and deciding who has a better outcome. Not for the procedure. AI has not really been put into any procedure or stuff like that for those outcome, but for others, predicting with the data that was already in the system, who can pick this up diagnosis quickly, and then who can put into use also. Most of the hospitals here, they do have the, as I mentioned, the screening triage, where they triage way ahead. And then if instead of a nurse who usually triages this patient, if you put the AI ahead with the encounter, will it make a difference? That experiment is on.
Okay, sir. Thank you.
I think there are two questions in the chat box. One is the question from, kindly unmute Nimisha. Please unmute Nimisha.
Sir, one question in chat box. How to
Yes.
enhance the skills of medical professionals, those who do not have the basic knowledge?
So I want to reiterate basic knowledge of the AI versus basic knowledge of the medical care. If they don't have a basic knowledge of the medical care, medical thing, they should not have the license. So that's no go. But if they don't have the information about the AI is like a is like a new child in the block. Like everybody wants to have it. Everybody wants to hug it. It's almost like a teddy bear. You want to hug that bear, but be careful. Bear can be intimidating. In fact, when I was going to different hospital, different hospitals have different AI system, because there are so many companies make so many things and they advance so fast. You go to one hospital and you go to another hospital, then all of a sudden I was thinking, are we going to go through the same problem like in electronic health records? And come to find out, it won't be that way. Means it can be integrated across the system, means because you're basically putting the same system, same data, same information. It's basically how you're processing it. How do you educate the clinician? It will take time, and I am the first one to say we clinician hate change. And unfortunately, the only constant in any equation in healthcare is change. That means we had to be adaptable. We had to, change. Whatever that we learned in 1989 when I went to medical school is so different now. Organs have not changed. Liver is still on the right side, brain is still in the brain. People have only two eyes. Those things will not change. But what has changed is basically how do you manage the disease in a different way? And that has changed. Yeah.
So actually, I have asked you that question. So my point is like the output which you are expecting from AI is always depends upon the depends upon your input. So output which you are expecting, so that always depends upon your input. So if your input is accurate and correct, then we will get the correct output. So how to enhance the skills of the any person? Just I mentioned about, now we are talking about the healthcare professionals and all, but even in a general scenario, like even how to enhance the skills of the people to give the correct input. So if you ask, even for the selection of any restaurant, just example I'm saying, I want some restaurant in X place. So if I give that thing, that is the same output will come. So if I have to get the more information, more input I have to give.
Right. So this is an excellent question. This is called GIGO problem. GIGO problem. Okay. Garbage in, garbage out. So whatever you put into this AI healthcare, the AI arena or the input, you can expect the same. So also with the training, right? if you have an excellent teacher, you're likely to have a better physicians, right? If the teacher is mediocre, maybe. What I'm saying is, it is a learning curve, and it's not going to be easy, because what we have learned so far is a different way. Whereas the new providers, new clinicians that are coming in, they're adapting like crazy. They carry that ambient thing, they walk, they touch the patient, they make the. I was a program director in a hospital. So they would go and see the patient, they'll come out within 10-15 minutes. That would take like 30 minutes for me or 40 minutes for me. I asked them like how? Yeah, everything is get recorded. I can see the patients do all this XYZ. I can finish so fast. So instead of seeing like 10 to 15 patients per day, they are seeing about 18 to 20 patients a day. That's remarkable. So basically, it is in the pudding of how to train them and then adapt to them. Believe it or not, some of the nurses, according to the facility, they love this idea of this monitoring. The putting a monitor for the patients for so many, because you cannot really go and check the vitals on everybody every time so often. They loved it. Then the real problem came up. Too many alerts. The machine keeps on beeping even though the blood pressure went up by like a couple of points. Then somebody has to be managing it and readjust it. This is where the retraining of the AI comes into play. They cannot take only one data and then just create an alarm, and that will take away the real time from the clinical care, and they're redefining it. So the AI is getting better, the humans we are adapting to it are also getting better. I hope that answers the question.
Hi, sir.
Hi.
Hi, sir. I have one question. Yeah, myself, I'm a primary care physician, practicing physician. So I had been trying since a long time to make use of this digital innovations into my day-to-day practice. And whenever I try to make use of this thing, the thing is like, I think the first telemedicine practicing guideline of India, it was released in 2019 or 20 recently. The scenario is almost the same with almost all governments. Currently, I am practicing in Saudi Arabia, and the law is little more rigid there. So the first rule is like the telemedicine consultation, it's equivalent in all aspect to in-person consultation. That is the first rule. So my question is like, suppose we are using, I think that we are not into that kind of relying on AI absolutely for a decision making or diagnosis. But when it comes to, suppose we are using different kinds of IoT, like remote monitoring systems, and based on that decision, we are making a diagnosis, or sometimes we have been forced to make an intervention. So when it comes to an intervention, there is a margin of error. The margin of error is there even with the best clinician. So the thing is like, when it comes to the liability, so the law says that the telemedicine consultation or digital health is equivalent to that of in-person consultation, so that the liability comes to the physician. Suppose in case we are using some IoT devices for remote monitoring, or maybe some algorithms for decision making and interventions, what about the margin of error, and what about the liability? I am very much confused about this problem, because when we are trying to launch a new project, this thing is a major question, and actually we don't have a pinpoint answer for that. Can you please throw some light into that, sir?
This is an excellent question. This is, in fact, believe it or not, so I worked as a TCDS, means Time Critical Diagnostic Services. It is one of the system that was set up in the state of Missouri. It's mid part of the USA. So I was one of the evaluator. There, we would go to some other hospitals and says, yeah, well, why don't you guys get the tele, the neurologist from the bigger facility? They would say, who will take the risk? They would ask the same question. Who will take the risk? Is it the doctor there? And then they say, why would that doctor take the risk when we are not paying anything for them? So come to find out, it was in the billing. So the provider on the other side, who is going to consult for this patient in this small facility, can bill for the services. When they bill for the services, they're taking the risk. When they're taking the risk, that means it's a liability. So the question is, during the telemonitoring, can they get more detailed information? That has something to do with the AI providing more information versus the physicians taking the margin of error. So it was all with the billing. If there is no billing, if there is no transaction, then there is no problem with the liability. So they get paid, they take the responsibility, but obviously it comes with the risk of that marginal error. Marginal error includes medical decision making.
Right, sir. Thank you so much.
Yep. But again, different countries go through a different thing. In US, if I'm working in an emergency room, I called on another hospital in a facility and then try to transfer the patient and give all the details. And if that provider tells do XYZ, he has already taken the risk.
Yeah, I got
Even
it.
though he has not met the patient, he has not seen the patient, he is going with what I am telling. And then the next step, as you said, is can the AI take that risk because you are not doing it, it's the AI doing it.
Yeah.
Excellent.
All right, sir. Thank you.
You're welcome.
Thank you, Dr. Sarath, joining from Saudi Arabia.
Yep. Thank you.
Thank you.
Sir, too many questions in chat box. Another question is how AI will play in giving moral support to patient.
This is an example. This is a good question. Believe it or not, a lot of the patients actually don't want to talk about this mental health issues. Mental health issues usually tend to kind of confine into the living space of the person, specifically if they have the real medical conditions where they want to talk about it. In fact, online, a lot of information is coming out through the AI system with some of the patients that they can actually open up and talk, and come to find out it's actually much better than medications. So it has been helping a lot of them. The other issue is if the patient goes home with an advice from the provider, say patient had a gallbladder surgery, you write down 10 advice to them, 10 advice like, don't do this, don't do this, don't do this, don't do this, do this, do this, do this, do this. How many people can remember? Can. What if we have a device or a way of putting that one in a nice format way, whether it could be in the phone or it could be in some kind of memory telling, reminding them, don't do this, do this, don't do this, do this. It could be a simple sensor. It could be a very simple sensor only for the first few days of the surgery. Think about that. Think about how much complication you would prevent them coming back to the hospital because they did not follow XYZ that was sent at the time of from the hospital. So it does help. It does help. And there are a lot of new innovative ways that are coming up with discharge planning. One of my friend, Dr. Anand Uttaya, he's a surgeon. He came up with an innovative idea of discharging the patient in their app, with their app, like what are the things that they need to do rather than carrying a big chunk of 10-page notes that you send them home at the time of the discharge. Thanks. Yep.
Thank you, sir. Next question is how the AI system integrated into medical devices. Do LLMs are standalone with the system?
So Both are happening parallel. The one with the language system model is actually going to get much better, robust outcome rather than a standalone. There are few standalone thing that they're doing. So one of them is something like um, the glucose monitoring system, right? So it is their own thing that they came up with. At some point, government is going to force them to work with the other system because the disease is not specific for that person, right? The disease, diabetes runs among everybody. So they may have to use the same platform across everybody, then they may have to be forced across to merge across. This is where the mergers and acquisitions happens because whoever is the leader in that field with this medical device technology tend to kind of overtake. To give you an example in a context, not necessarily with the AI, with the other. So Boston Scientific does a lot of things with the Medtronics, um, uh, the pacemaker. They are so expert, nobody else really can compete with them. They are so good at it. Whereas somebody who makes the stent is good at their own line. So just like that, that's where a lot of innovation comes into play. And of course, it comes with a lot of cost, but that's where the innovation comes. But when you're putting into a huge system to use or putting into a population to use, some government will force them to merge and then make sure that it is affordable. Because if it is LSM, it's less expensive than a brand new innovative in your own line, kind of innovation. I hope that helps with the answer. Thank you.
Okay, sir, thank you. The next question is, what are the required accreditations and permissions for AI approval in healthcare?
This is a very good question. Nobody has a real answers, to be honest with you. All this technology that the hospitals are putting are approved by FDA. The Food and Drug Administration, they have a separate branch for approving all this equipment and stuff like that. Whereas the technology itself is just like an improvement in the healthcare. So there is no regulation in that field as such, and that's where the tricky part is. And that's what everybody is asking them to come up with. Are they going to self-regulate themselves? This is the same thing in the other industry too. Versus the healthcare is a big gorilla, is a big elephant in the room because there is a lot of money in it, right? Everybody cares about healthcare at the end of the day. That's what it is. So there is a big umbrella, and then so these whenever this the hospitals do this innovation thing, they do like an experimental thing with an approval with the internal review board within the hospital, and they'll say whether it is works or not. If it does not work out and if they see some complication, then they pull that health the AI system that they were planned to implement. With the device, it has to be approved by the FDA, the Food and Drug Administration. Different countries have a different methodology of monitoring, but to put into the implementation phase, they had to go through the internal review board or IRB, internal review board, that tells what are the risks, what are the benefits, does the patient has an approval to use. To give you an example, recently we have a lawsuit in the state of California, wherein California state has a rule that to listen to the patient's talk between the provider and the patient, you had to take a consent. Come to find out, the consent was not taken. That's what the patient is saying in the court of law. So obviously it has not gone to litigation, it has not gone to this thing, but this is a case where the patient is saying that nobody taken approval for my conversation. The conversation between me and my doctor is a private, and it was not requested that another third company, which is basically the AI ambient recording, is recording my conversation, and I was under the impression it was all private and it between me and the provider. I did not know the other person was recording it. So there is a lawsuit. So the consent has to be taken from the patient before you put all these patches on them. Means even when they sell these the patches for the or the monitors for the diabetes monitoring, you had to sign a consent. When you pick up those things from the pharmacy, that actually says I'm approving this one to use it for my medical condition. So there is a consent part that has to happen, whereas regulating each and every innovation that is coming up, they have to go through a process. So that's how it is been set up in the US. I'm pretty sure each country has their own rule. But when they're experimenting, say for example, one AI company will approach a hospital and say, "Hey, I have this model of monitoring doing this XYZ. Can you let us do work with you guys?" It goes through the IRB. Yes, it is approved. They can put into place, and there's no regulation on that. Thanks. Any other questions, Dr. Sujita?
Sir, one another question about NEP 2020. Kindly clarity on the role of artificial intelligence in the new education policy, National Education Policy 2020, in achieving the goal of Vikasit Bharat 2047.
I cannot talk a whole lot about the government regulation from India, but I do know this part from the US. A lot of the academic providers are kind of baffled as to how to train the new providers, and that is because traditional method is kind of going away. And then also they always say if you need to train the AI methodology of learning, what do you take out? What part of the education that you are doing you need to take out? Because as I think Dr. Sarath mentioned, right, the GIGO problem, like what you input is what you're going to get, the GIGO problem. So they're deciding what part of the education is not needed by these new physicians that can be taken off so that they can learn a lot more about AI. Because within that 4.5 years of training, you had to learn so many things. And if you can add the AI as another layer that they had to learn, you had to take something out. That part is not clear, at least in the United States. But I do know some of my friends who are the department's head and the professors and the academic principals and the dean of the Manipal Hospital is my classmate. So they talk about the difficulties of putting this AI versus traditional medical training that we have been used to. There is a significant shift. And I believe with this new government regulation, I would not, I would be hesitant to use this word. They're kind of copying from the United States.
Sir, let me add one more line.
Things that are happening. Yeah.
As such, this NEP is concerned, there is no separate pillar for AI alone, but it becomes a powerful accelerator towards the national vision of Vikasit Bharat 2047. So in summary, what you also said is in line with this. And also, as you see further on that line, multidisciplinary education, as example is bio plus AI or health plus AI, whatever comes. And also it says about the skill-based learning, which is outcome-based learning. Then the another part is digital and online learning education, and also research and innovation. So, and also NEP proposes the NRF, National Research Foundation, equity and inclusions, and also it becomes the economic growth by which we will see AI-driven industries. There is a lot of industries will be coming, and there is a healthcare transformation, and AI diagnosis also will happen. So these are all, and again, the smart infrastructure and governance, and all this comes under the NEP 2020, which will govern to the Vikasit Bharat 2047. So exactly, you also mentioned about that. So hopefully it will happen in India also. Over to you, sir.
It is true, it is happening. So the clinical learning base. So what we used to learn was, like when we train, was we read the whole books, we read about everything. But now it is a case based. You pick a patient and then you analyze all the diagnoses that they have, and you're gonna start learning about it. It's more of a hands-on training versus you learn about everything and somehow it puts into your brain, and then you spill it out during the examination time. So that was tough, but now it is a lot more hands-on training, which I think is a good way of learning for the future generation. Yeah. Again, healthcare
Yeah.
is important and it has a lot of money in it. And that's why so many people are getting on board, and it is going very exponential. Yeah.
Sir, maybe on the next coming days, you can also mention about what are the possible. Now, if you see that there are a lot of students as well as faculty members are joining. So the projects, a small project which we can, like a problem statement where you think that student has to work on that. So mini projects or something which you can highlight in the coming class.
Absolutely. Yep. Love to.
Yes, Dr. Sangeeta, questions.
Sir, one another question. Kindly give information on artificial intelligence in healthcare analysis with a special reference to machines used for virus detection.
Okay, so this is actually done within the CDC and also at the National Institute of Virology, where they're actually able to see and then determine with the genomic sequences that what used to take a couple of the weeks to determine, they can do it so quickly now because there is a lot of data out there, and they can also predict is there going to be different varieties of the new virus that's going to come up. This used to be done like a manual thing in the past, but now it is pretty much getting automated. So if you hear about this is all because of the COVID, why we are taking so much of leap in learning this new variant that's going to happen so quickly. It would take, like say for example, the influenza, right? So they would predict what are the models that's going to happen in a couple of years. Now the AI is doing that in a much better fashion, much faster way. And this is the same thing that they're also using with the measles outbreak in different location. What are the strains, how to mitigate it? This is, I think I did include in my talk, this the determining the variations in the virus that can cause, and also what to expect that might happen in the next few months or few years is also done by the AI. It's not, I don't know if it is really put into complete action, but it is in the process. Again, the microbiologist and the pathologist, all this work has been kind of reduced with the use of the AI and reading up the slides and reading up the microbiology, the reports and all those things by the AI. And I'm pretty sure it's happening in India also.
Thank you,
Okay,
sir.
thank you, sir. Sir, one last question. Being a CS, what steps can we take at school level to encourage students' interest in AI and healthcare?
So here is the good part. Asking the question is actually a good start. And then once when you ask that question, you already have an answer. In fact, if you talk to some of the young people, they don't want to do the same thing that some of what I call as old people. They want something quick. They want something immediate. They want the gratification, and the AI can do that. But it comes with risk. So I had to. I'm the first one to say. Sometimes you Google and then it says, "I got these symptoms," and then the first thing that Google says, "Oh, you have a cancer." Okay, and then they end up in coming to the hospital, and then we had to give a reasoning. It's like, "No, you're not gonna die. You're all right." So if they learn that one and flip it the other way around, let me learn a little bit more about the AI. Let me learn a little bit about this, thing, and then how exactly to help the patient. So if this is for the medical community, it's even better. So the newer generation wants a quick results, quick outcome, and the AI can do both.
Thank you for
So
the engaging.
yeah. So if there are no other questions, I would like to thank the organizer, especially Dr. Sojan and the team who have done an outstanding job in reaching out to us. And then would like to take part more. And then my teacher, Siddhganga Swamiji, always used to say, knowledge is power, share it. Share it with other people. Some people may not have all the knowledge. At least you will also learn from the other people. And that's what I always believe. Learning from you, getting the questions, and then also thinking about the different way of different things people do. The gigo problem that was brought up for the discussion. So that's the way to learn, and then encourage among ourselves to learn new things and be innovative and be ready for this constant change in the healthcare. Thank you all.
Thank you,
We'll
sir.
see you.
It was a great privilege having you. Within the short time through Siddesh, we connected, and for the audience, and the doctor and along with his colleague will be there for another 3 more days. So get ready, and and not actually even 4 days. When the panel discussion also comes, and so separate sessions are also coming. So that's a wonderful opportunity for us. And I also see that this our artificial intelligence AD department has managed everything in a very short time. But we are very powerful persons like you, sir. And pranams to Siddhalinga Swamiji ji. I am also a devotee of that institute, which you also know about that. So if you have no further questions, I think thank you very much. I think it's a midnight for you and waking up. We know that
It
the
is
time
5 o'clock in
difference.
the morning.
What is the time?
It is 5 o'clock in the morning.
Morning, so early morning, got up.
Yeah.
So almost just 12 hours difference. That's a great opportunity. And again, sir has already promised that every day at 1 p.m. Indian time, he will be available. So grateful to you, sir. Thank you very much.
Thank you. Bye-bye.
Nice.
On behalf of the organizing team, I extend our great heartfelt gratitude to Dr. Nagana for sharing such a valuable knowledge and insight with us today. Thank you, sir.
Thank you.
Thank you, sir. Namaste. Thank you.
Good afternoon once again. We now move forward to our next session, which focuses on critical aspects of AI, transforming data into meaningful decision. The session title, From Data to Decision, a Systems Perspective on AI in Healthcare, will explore how data, intelligence, and critical decision making are interconnected. We are now privileged to have Dr. P. Sojanlal, Principal, Jyoti Engineering College, Kerala, as a panel lead for this session. He is an inspiring academic leader with a deep insights into system thinking and interdisciplinary application. It is a privilege to introduce Dr. P. Sojanlal, Professor CSC and Principal, Jyoti Engineering College, Kerala. He is an accomplished academic leader with 39 years of extensive experience in engineering education, institutional development, and industry-aligned learning framework. Dr. Sojanlal has been instrumental in driving initiative that enhances graduate employability, innovation, and research culture. His work focuses on bridging academia and industry, fostering outcome-based education, and promoting holistic student development. He has supervised 6 PhD scholars and authored 26 books and has 80 publications. He is widely recognized for his leadership in transforming academic ecosystems and for his contribution to advancing engineering education with a strong emphasis on real-world readiness. I now invite Dr. Sojalal to lead the session. Over to you, sir.
Thank you, Anjali, for introducing. And as you know that we had an exciting session, so it has come and extended here. And also I'm aware that most of the colleges, you will have time only up to 4 o'clock. So you'll be rushing to this. And we also seen that now, we have seen that medical doctors are again joining with us. We have the industrial data. Just would like to give a little summary of what is happening for the next few days. Cognizant, TCS, spin theory. So we have put a mix of academia, industry leaders, and internal faculty members for all these sessions. So kindly join with your teammates, students, if available, or friends also. So now, why this diagnosing disease from a difficult? I think as you are already heard about this, and from this practicing doctors, same symptoms, different diseases. Same disease, you will have different patients. And data is incomplete and noisy and heterogeneous. So this may be some of the challenges for our own people, particularly who are working on the computer domain. Humans find it complex and how the machine can handle it. So that is another concern. And also when we look into the healthcare data is fundamentally different. And it is structured, the lab reports, unstructured, the clinical notes, and imaging and time scaling. And I think Dr. Nagan has already mentioned with his tools, which is different data points, which is getting from the patients. He mentioned about that. So how we can handle this data? So high variability, high stakes. And this may be for a computer professionals, this may be the system flow. It has to happen from the data, pre-processing, features and model. And of course, everywhere you'll have the feedback system and model, prediction, clinical decision. That's how it going on. And we have bridging the machine with the healthcare. And how do you do that? Bridging medicine and AI. So based on the symptoms, diagnostical, clinical notes, imaging, X-rays. So it is AI augments, not replaces clinical reasoning. So which I already mentioned about Nagana sir. And this is little bit on the technical side on the faculty members. You have to go for the pattern recognition, risk prediction, classification, decision support. And there are examples. Some of them are already listed: tumor detection, ICU alert, disease screening and all. Now, we are also mentioning about the high impact use cases, which are summarized as radiology, ICU monitoring, predictive analysis, screen systems. So limitations and this, I think in one of the sessions which is covering, there are 2 days, you will see about this limitation and this. And based on the bias in data, lack of explainability, false positives, negatives. In healthcare, actually, what we are looking for is, it is perfect one, but without any errors. So finally it comes, the system will be supporting for this. And finally, the clinician will take the decision on this. So from the model to systems, AI will definitely assist only. Doctors will decide, the system only will support. So the model what you're preparing is not a solution to this. And the deployment challenges, data drift, and integration validation. So trust is building through the transparency validation. So I think one of the questions was asked by somebody in the audience also about this. And as we move along, we will hope that we'll have a perfect system, which again support the clinicians and also will give an easy access to our people. And human plus AI collaboration is the future which we are looking for. It's AI assist and doctors will decide. And trust is built through a transparency, validation, and their own experience. We are also preparing for the next generation is building the AI capabilities. It's starting from the concept of understanding, problem-based learning, and real-world exposure, and continuous practice. You must train the students to think, not just to code. And just to summarize this, healthcare is an AI system driven. Data alone is not enough. What is required is decisions required, context plus validation. So AI must be trusted, not just accurate. The future of healthcare is not AI alone, nor doctors alone, but an intelligent collaboration between the two. So here I'll just summarize what you are going to have for the coming days. One is a foundation day, which we have already elaborated, and you listen to that. And tomorrow, the second day, you'll listen to the data and systems. And the third day, you'll learn more about the tools and data sets. And the fourth day, as Dr. also was mentioning about ethics. By the way, just some of the days, because we are already getting some experts, they may have their own commitment. So there is a possibility that anything what you listed in the program sheet may also get swapped between the availability, but the points will be covered. Then the deployment, integration, and the last day we'll have lots of questions will be there. Maybe you can also give your questions in advance so that you can also give to the panel members in advance. So maybe I'll request my team to circulate a questionnaire where we'll have lots of questions so that during the day 2, 3, 4, 5, and 6, we'll try to answer your basic fundamental questions and all. And there's a very brief which I'd like to mention to you today, because the time is also running fast and most of you would like to leave the campus. And thank you all for joining this.
Thank you, sir, for very engaging and thought-provoking session. I am sure the session has given all of us a clear understanding of how data can be effectively translated into meaningful clinical decision through a systems approach. We would now like to open the session for a short interaction. Dear participants, if you have any questions, observations, or points for discussion, please feel free to interact with us.
Or else alternatively, you can also give us, we can also, Anjali, we can circulate one questionnaire which they would like to ask the questions so that it can be spread to our different panel members also.
Sure, sir. Participants, please ask if you have any doubts.
I think no answers, we can conclude.
I think there is no more queries. We will circulate the questionnaire. You can ask the doubts there. Okay. We sincerely express our gratitude to Dr. P. Sojanlal for delivering such informative and well-structured session. Dear participants, we request you to kindly share your feedback using the link provided in the chat box. Your inputs are valuable and will help us to enhance the quality of our future sessions. Okay. Today we are going to wind up. So looking forward, tomorrow we can have more good sessions. Okay. Thank you all. Please fill the feedback and you can exit.
Please to join before 1 o'clock tomorrow positively. Thank you all.